Okay, this will be a first video of a series where we explain very common mental disorders. Today, I would like to start with body dysmorphic disorder. I'm a professor of psychiatry and consultant psychiatrist, and I live in Glasgow, but that's irrelevant. What I'd like to give you some information, and this is from information for people who are relatives, who are patients, and they might or have a problem which might be related. And today we would like to talk about body dysmorphic disorder. Body dysmorphic disorder is not very common in the mental health system. It's something relatively new. It's a preoccupation with the belief or with the thought that the physical experience of a person is ugly and unattractive. So many people might believe that, but the question is, why would that be a problem? So some people believe that, let's say, their nose is too big, their ears are too small or too big. And the question is, many people believe that, and they have a normal life. People with body dysmorphic disorder spend an awful lot of time thinking about that. And they also might go to get some therapy for that. They might go to the doctor and say, my nose is too big, too short, too long, and say I'm ugly, and for that reason, I can't cope. And even though the actual problem might be very, very small, people have a lot of distress, and they just can't continue, or they can't stop thinking about that. In this respect, the body dysmorphic disorder is very often seen as a part or type of obsessive compulsive disorder. Obsessive compulsive disorder is a disorder where people have obsessions, where they permanently think about something. So that's the obsession. And the compulsion is when they act. So that might be counting numbers, going up, down the stairs in prime numbers. But let's forget about that today. So we have this quite unusual issue of body dysmorphic disorder, and this can be classified in some areas as an obsessive compulsive disorder, but now in the recent classifications, it's quite independent. Some very odd things is which you more or less possibly more likely see on TV, and most people wouldn't ever see this when they're psychiatrists, which are body integrity disorder, where people feel that they have to have something, they have the desire to have a physical disability. So I think where people want to have amputation of a completely functional normal leg. So this is something unusual, but body dysmorphic disorder is usually thinking about the fact that some parts of the body are disgusting, people can't stop thinking about that, and then they just try to do something about that. So it's a preoccupation with an idea that some features of the body are disgusting and should be changed. This can very often it's in the face, it can be in the head, it can be whatever in some female or male sexual characteristics. Right, people then believe this is noticeable to others, and then they might think that others have a specific way of responding to that. So that people might see them, they might avoid them because they might be affected by looking at this ugly or assumedly ugly nose or assumedly ugly face. This preoccupation then leads to the way of trying to hide this. People will try not to look at other people, and sometimes it becomes completely delusional, so that people look at me simply because I have a big nose or a small nose or too big ears or anything like that, or whatever, too small or too big eyes. Usually because people then spend an awful lot of time that there is function impairment. People avoid going out, that's what we call agoraphobia, or they even have an increased risk of suicide. Sometimes People try to affect something. They start, if they have something on the skin, they start rubbing their skin, or they do other, try to put some cream on it, try to avoid things. And the one most important point is that there is a severe impairment and an awful lot of stress with that. Okay, right. And then it might affect relationships, it might affect a marriage, it might affect people not being able to go to work. And some people develop this after a surgical procedure. Usually, and this is the question is, when does it begin? Usually it begins in late childhood, early adolescence, and sometimes it starts with the normal worries of whatever, puberty, changes of physical appearance. Usually the gender difference is very limited, so more or less you find the same thing in females and males, and the prevalence means how often does it happen in someone's in the population. Usually people say it's less than 1%, but in some areas, so let's say in dermatology, there people are much more seen. There was a recent paper we published in Global Psychiatry Archives where we looked at the prevalence in different areas, in different populations. If you want to have a look at this paper, look at the website of Global Psychiatry Archives, the journal, and look through the index. So there is an awful lot of incidents if it's in the family. If it's one member of the family, very often another family member has the same problems. As I said, lots of people go to dermatology, lots of people are in plastic surgery. The question is, very often when these people get an operation, it doesn't get better. So sometimes one operation makes people want more operations. Right. There is lots of comorbidity with depression. People have a depression when they have that. Sometimes they have social phobia. As I said before, people will avoid going out. They're hypochondriac. They have somatic delusions. That can happen in schizophrenia and other disorders. People with anorexia, there's an overlap with people with anorexia. People with anorexia nervosa feel very often that they're too fat, even though other people would see them as extremely thin. Right, so what do we do about that? And some people say, okay, try plastic surgery if there's something can be done by surgery. The problem is, in general, it's not indicated because in most cases, one surgical operation follows the wish for something else. There's some studies which say that there is some effect of medication, which are SSRIs, antidepressants, and in severe cases, you can try an antipsychotic. I wouldn't go on what antipsychotic, which antidepressant. I'll just say it in general. One can try in severe cases. There's another thing, some evidence for CBT, cognitive. CBT is cognitive behavioral therapy, which tries to change the cognition and the perceptions. Sometimes we have people who have very long-term problems, and this can be quite debilitating. And in many cases, especially if it's not properly treated, possibly a combination of an antidepressant, maybe an antipsychotic, and psychotherapy, then the full remission is more rare than anything else. But there are different variations. Some people might have some problems, and at the end of the day, like most disorders, that varies very much. I hope you're interested in this, and I hope you can post this. Okay, thanks a lot. And yes, I would like to have some feedback. Let me